welcome to this MedEClasses lecture series on delayed puberty in girls. And this is part of our initiative, a monthly initiative in which we propose to cover the entirety of pediatric endocrinology from a pediatrician and pediatric trainee perspective over the next 36 months. I'm pleased to be joined by Dr. Vibha, who is a consultant in pediatric endocrinology at Regency Health, and Dr. Dhwani, who is a fellow with us at Regency Center for Diabetes, Endocrinology, and Research. So this is a very, very important topic. And what are the key things, Dr. Vibha, you have to understand in terms of when you are evaluating a girl with delayed puberty compared to boys with delayed puberty?
In compared to the boys, the presentation, the cause of the delayed puberty in girls is mostly physiological, is not physiological in comparison to boys. So we have to firstly rule out the systemic causes and other pathogenic causes or the organic causes in comparison to boys.
So although we have got lesser number of girls who come to us with delayed puberty, we need to be more worried about that in that perspective. So Dhwani, in your experience, what are the common presentations or common causes of delayed puberty of girls?
So again, as ma'am has mentioned that when you have a girl with delayed puberty, you have to be wary of it being a pathological cause. However, we've seen that about 1/3 of these children are actually physiological and self-limited delay of puberty. However, the most common causes that we encounter are probably hypothyroidism, Turner syndrome that we commonly see in our day-to-day clinical practice.
So celiac, hypothyroidism, Turner syndrome, these will be a very, very common. So we have this 13-year-old girl who had presented to us a few years ago with concern for delayed puberty. She had stage 1 breast development and stage 1 pubic hair development. So parents were concerned that she was not having puberty. She was short for the age, weight was reasonable, and somebody had done a workup which showed a low level of LH and FSH. To compound the matter further, ultrasound had been done by the referring physician who found an absent uterus. Now, this was a very devastating scenario for the parents. They were very concerned about the puberty, breast not being there, and ultrasound showing an absent uterus, which was an entirely disastrous scenario from that regards. But what we need to understand is that 13 years is just the edge in terms of the time when puberty should happen. And in this scenario, clearly, we need to understand that when the breast is developing, the uterus will take time to develop. And at breast stage 1, we can often miss a uterus on a transabdominal scan. So this case really highlights the importance of not doing unnecessary workup like ultrasound. And this case better would have been to wait and watch. And this is what we did. And the girl had a normal outcome subsequently. The second scenario was a 14-year-old girl with delayed puberty. Now, this is from a different perspective and dynamics. She had presented with stage 2 development with pubic hair stage 3. So what looked like that she had some development to begin with. This is what the parents said. And then the development had stopped for the last year or so. Again, the same thing was found. LH was 0.1 and FSH was 0.1. And people thought that, okay, like the first case, better to wait and watch. This was labeled as constitutional delay. Now, as I'll talk subsequently that when somebody has a stalled puberty, it has got an entirely different connotation as compared to a classical case of delayed puberty in girls. And in this case, we should be worried about our underlying cause, which was missed. And she presented later with seizures and glioma. So there seems to be a quick balance with regards to not doing unnecessary workup in delayed puberty on the one hand, like in the first case, but also to not miss a cause, which is very important. This is what we'll try to focus over the next hour or so, is to develop clinical pointers to suggest pathology and do a reasonable amount of workup without overdoing it to identify the cause from that perspective. Now, delayed puberty, as we discussed, is common in girls. Approximately 2.5% of all girls have delayed puberty. As Dhwani was talking about, 30% to 40% may be physiological, but we can have other pathologies like hypogonadotropic hypogonadism, less common as compared to boys. Functional causes like malnutrition, systemic illnesses, more common in girls compared to boys. And of course, hypogonadotropic hypogonadism with Turner syndrome leading the list is definitely common in that regards. So our role is to not unduly investigate these 30 to 40% with physiological causes, but not miss these 60-70% who have a pathological cause in that regards. all of you should go and have a look at our website, learning.growsociety.in, which has got a lot of resources with related to pediatric endocrinology, including a number of video lectures which are available and courses in terms of that. We have our e-learning platform on YouTube, which has got a large number of videos as well. And we have got validated courses in terms of pediatric endocrinology, including a full hybrid fellowship program of a 2-year program, specific pediatric endocrinology course for postgraduates, which is also available. We have got a full spectrum of books ranging from pediatric endocrinology protocols, which guide the pediatricians and pediatric trainees for basic workup, to basic pediatric endocrinology, which is covering pathophysiology as well, and advanced pediatric endocrinology covering the entirety of pediatric endocrinology. Our mobile application, which I'll touch base later, is one tool which helps in terms of point of care management in that perspective. So today we're going to focus on delayed puberty in girls. We already recently had series on precocious puberty in boys and girls. That's available as part of our YouTube channel, and you can go and have a look at it. I am joined, as discussed, by Dr. Vibha and Dr. Dhwani, who will be focusing about different aspects of delayed puberty evaluation from that regards.
A 16-year-old girl presented with delayed puberty, and on examination, she has a stage 1 breast and stage 1 pubic hair development, and has a height of 135 centimeter and a bone age of 10 years. Now the timer starts of 2 minutes. What is the definition of delayed puberty? Write only the year.
So
Name the hormones regulating
so
breast.
maybe we'll give some time to, we'll see how people are responding. So all of you can just put in your answer on the chat, on the Q&A. Yeah. So not achieved Thilarki by 13 years. So everybody is agreeing. Dr. Sandeep, Dr. Medha, Dr. Arul Nathan, Dr. Adele, Dr. Edesola, all of them have mentioned 13 years. So I think this message has gone really well. No breast development by 13 years.
Okay,
Next
fine.
one.
Now name the hormones regulating breast and pubic hair development.
Yeah. So I think this is something which we discussed in detail. So Dr. Medha has already mentioned, just hold on. So give people answer. So Dr. Medha has mentioned breast estrogen, pubic androgens. Anything specific on androgens? We are looking at a more specific answer for androgens. That would be, anybody is coming up with the adrenal androgens, that is DHEAS. Dr. Shubhadeep Paul has mentioned DHEAS, Dr. Sheikh Mahim. So yes, I think we're going fine from there. The next question.
So what is the likely finding on the ultrasound for uterus, especially at in this case?
Yes, so this is very relevant. This is just that she has breast stage 1. So what you may find from the radiologist, uterus paper thin use, yes, you can have absent uterus, may be missed. So I think that's an important message that we wanted to give, tubular uterus. So I think both are right, but there may be a few chance that somebody who's not that experienced may miss the uterus also. Yeah, yes. Carry on.
What are the key findings that you should look for in the examination in this case?
So maybe one finding you can mention.
Yeah, one finding, any one finding.
Most important finding, of course, in a short girl who has delayed puberty. Pubic hair, yes, a lot of people have talked about pubic hair. You have mentioned pubic hair already. Stage 1 pubic hair is there.
Yes, it's given.
So something else, one clue, you of course have to look the whole child, but one thing which will give you the diagnosis would be Turner stigmata. So wide carrying angle, brachymetacarpia, web neck. So I think the message was very, very clear. And
last one is, what is the most critical investigation that you would do in this case?
Yeah, short girl with delayed puberty, the most critical investigation. Already we've got Dr. Medha who has mentioned FSH, Dr. Adiokia has mentioned karyotype. So yes, so I think both of them are important. So FSH, karyotype, I think the answer is pretty clear. So I think we'll move forward to the next one, Dr. Vibha.
Next question directly, sir?
Yes, yes.
So here's the next question. We have this 14-year-old girl presented with delayed puberty and growth failure. She had a height of 135 centimeter and a weight of 35 kg with a BMI of 19.2. On examination, she had a breast stage 1 and pubic hair 2 with a webbing of neck and brachymetacarpia. She presented with an abdominal lump on follow-up. So what is the most likely diagnosis? I think this is the easy one.
So I think this is very, very clear that this is case which we discussed also. So this is Turner syndrome with Y cell line. Dr. Edele, Dr. Edasola, both have mentioned Turner syndrome with gonadoblastoma, right? The most next point, Vibha.
What are the most helpful investigation for making a diagnosis in this case?
So yes, so we are looking at karyotype. Dr. Shubhadeep Paul or Dr. Arul Nathan have mentioned karyotype. So I think Dr. Edele, so I think yes,
Yes, sir.
karyotype and FSH.
And what should be done to prevent the abdominal lump in this case?
Yes, so I think this is very, very important. So what could have been done and what should have been done earlier?
Yes.
So to prevent the lump, if you have a Y cell line, you have to, let's see what people are saying, do a gonadectomy. Dr. Shubhadeep Paul is mentioning gonadectomy, remove the gonads, gonadectomy. So I think very clearly any girl with Turner syndrome, we should do a Y line if there is a suspicion and get a gonadectomy. Yeah, carry on.
What are the key examination findings associated with lumps? Then what will you get if the patient is having lump?
Virilization, true. So if there is a Y line, if there's a gonadoblastoma, you can have virilization. So I think that was a very good answer, Dr. Arul. Yeah.
What are the three most important screening workup to be done?
This is clearly a case of Turner syndrome. We should look at various things. So three most important. I think people will take time to put in. Echo has already come. Hearing, echo and ultrasound, Dr. Sandeep. Dr. Adelaide, thyroid, cardiac, hearing. Yes. Maybe add renal as well. So that is a very, very clear-cut case of Turner's in which we should have missed the Y line. Carry forward.
Coming to the next question. We had this 14-year-old girl, sorry. This on examination, her height was 144 and weight 36. Both were low, but appropriate for born age of 11 years. She had a breast stage of 1 and stage 1 pubic hair growth. Lab investigation showed an LH of 0.2 and an FSH of 1.1 with an estradiol of 30 nanogram per day.
So there is a
So what is
girl
the
with,
most likely
so
diagnosis?
girl with delayed puberty who is slightly short and has no pubic hair. So people are already going into CDGP. Do you agree, Vibha?
Yes, sir, CDG.
So this is classically CDGP. So Dr. Adelaide, Dr. Arul, Dr. Sandeep, Dr. Edosala, all are agreeing to CDGP. Yes.
And what are the differential diagnosis in this case?
So I think differential diagnosis of no pubic hair and no breast development. So other than CDGP, MPHD, very good, Dr. Adelaide. What else are we looking at? Maybe a systemic illness.
Systemic, MPHD.
Yes, Dr. Sandeep is talking about, or a steroidogenic defect. So all three have come in. Dr. Sheikh has mentioned steroidogenic defect. Yes. So
what
next,
are the helpful tests that will help in making a diagnosis?
so yes, here you are pretty okay, but you want to maybe do some tests to exclude some disorders and do some stimulation testing.
Yes.
Yes, so somebody is coming up with that. Systemic illness should be ruled out. That's important. TTG, KFT, yes, definitely, Dr. Mehta. So that will be an important thing on that.
And how would you manage this case if this
GNRS
is
stimulation as well, Dr. Arul, which is fine. Yeah. How will you manage this case? I think this is important. So Dr. Edosala is mentioning reassure, which is also acceptable because bone age is 11 years. If it was about 12, we should definitely give estrogen. But if somebody says estrogen, we are not also against because she is 14 years old already. So Dr. Shubhadeep has given the answer of estrogen / observation. So I think low dose estrogen for 3 to 6 months. Yeah. Next case, please.
Next question. We have 16-year-old girl with primary amenorrhea and the normal breast development. On examination, she has a tall height of 163 centimeter with a breast stage of 4. And she had no pubic hair. So what are the differential diagnoses if we look for the stage 4 breast development and no pubic hair?
So I think we want one diagnosis and already people have started. Dr. Medha, Dr. Sandeep, Dr. Arul Nathan, Dr. Tahini, all are saying AIS. So I think that's the clear cut message.
And what
A
physical exam?
Tall girl with no pubic hair, a lot of breast development. So complete androgen insensitivity syndrome, Dr. Adele. Correct. Next question.
Which physical examination will give you a clue to the diagnosis?
So, yes, Dr. Mehta is saying presence of no pubic hair. That is something there, but something more.
Yeah.
We are looking at a positive finding, not a negative finding. Blind vaginal pause, tall, Dr. Sandeep. Anything else which is very easy to identify? Tall, everybody's forgetting the main thing. So this is a girl, but she has a karyotype of.
So that will confirm the
Yeah, so people will know, but
diagnosis.
what is there? So that's very important. This is a DSG. So you have got
Inguinal gonad there. will be.
inguinal gonad, that becomes important. Yeah. So next question.
Which investigation will confirm the diagnosis? Definitely, sir has answered. And
So-
how would you manage this case?
So you can get a karyotype done, and then you can have a high LH, high FSH, high testosterone. That will be another clue to diagnosis there. Yeah, management of the case again is very, very important. You will do gonadectomy, but when? So
When?
generally, so Dr. Sandeep is saying gonadectomy. So Vibha, when will you like to do gonadectomy?
So we do gonadectomy after the puberty because during the time of puberty we require this hormones, even the testosterone for the development or the mineralization of the bones. So
So
we
the
generally do
chance
it
of
after the
gonadoblastoma is very low before puberty
puberty.
in
Right.
these girls. So we should avoid that. Yeah. Should do it after that. Okay. Last case.
So coming to the last one, we have this girl who presented with delayed puberty of stage 1 breast and pubic hair. The pubic hair is also stage 1, and she had a height of 135 centimeter and the weight of 28 kg. Investigation showed low LH and FSH levels. On the
Already
examination,
people
she
have
had
mentioned
anemia.
celiac disease. So I think this is a very classical case of
Yes,
celiac.
sir.
Dr. Adosela is talking about celiac disease, but it can also be renal failure. Similar finding,
Yeah.
we've seen patients with renal failure presenting
And
like.
what key finding on examination would give you the clue to the
Yeah,
diagnosis?
and thalassemia. So I'm just not, I think with anemia and delayed puberty, if you want to carry on some other possibilities, Vibha. So one we talked about.
Renal failure, as you said, and again you have mentioned the thalassemia. It could be the cause of delayed puberty because of the repeated multiple blood transfusion that can lead to the
So
delayed
we need to
puberty.
be cautious on that regards.
Yeah.
Okay. So
So
finding on
what
examination.
examination, like clubbing,
We are looking for
if
answers.
we are looking for, yeah. And
So
what
finding on
screening test is helpful in this case?
So clubbing is mentioned by Dr. Arul, screening investigation. Of course, we have to do TTG. Dr. Shubhadeep, as mentioned, we also have to do other things as well, like creatinine, reticulocyte count, CBC. So all the other workup has to be done on that. Yeah.
Which investigation would confirm the diagnosis?
Provided you have a high TTG, then you will go ahead for a biopsy. Dr. Sandeep has already mentioned.
And definitely the management of the case, it's easy.